Hi, so thanks everyone for joining us today.
Sure. Good afternoon. Thanks everyone for joining us today. It's my pleasure to reintroduce Dr. Judith Martin. She is a family practice physician and addiction medicine specialist who has been working with patients and their families for over 20 years. She gave us a similar grand round several years ago, so it's very exciting to have her back. She's the past president of the California Society for Addiction Medicine and has been on the board of directors for the American Society for Addiction Medicine as well. Since 2012, she's been the medical director of the Substance Abuse Services for the DPH in San Francisco, where she's worked on integrated care issues in mental health, primary care, and addiction medicine. She also serves as the County Alcohol and Drug Programs Administrator, and as such participates in statewide behavioral health policy direction and implementation. She's led improvement projects and educational meetings in the Bay Area related to substance abuse disorders and treatment for over 15 years. And today she'll be speaking about updates on current trends with substance abuse disorders and medication treatments thereof. So thank you very much for coming today.
Thanks, Andrew and Dominic. When I was thinking about what to talk about here, I thought, well, trends. Let's talk about trends. And there are different kinds of trends. Some of them have to do with drug use, and others have to do with how we approach drug use. And I also wanted to give some tools, so mostly about medication use, because if you're a psychiatrist, you're a prescriber. And so that was how I approached this, but feel free to ask questions or change the subject if you like. So this is my disclosure slide. I work for the health department since 2012, so I don't talk to drug companies, or I don't consult for money, and I don't lecture for them. And basically I work for the public health department, so it's hard to have financial disclosures to make when that happens. And some of these slides I'm going to talk about off-label use of medications, and I'll let you know when that, it's usually on the slide, but if you don't, I'll let you know verbally as well. So here's what I decided to make our educational objectives for today, so that you can hear about drug use and overdose trends in San Francisco, so that you can know about some unusual new ways of thinking about the overdose epidemic and about approaches to opiate use disorder, in particular the cascade model and medication-first approaches. And then I'm including some information and patient selection material for alcohol use disorder, because that's a very common co-occurring diagnosis with mental health diagnoses. So here are some key trends in San Francisco. Every year, Dr. Philip Coffin puts out the NDUS report. We're one of the sentinel cities for the National Early Drug Use Warning System. And so I put the link on here too, so you can look it up if you like. This information is taken from the one that's just been put up in 2018, but it contains, of course, 2017 data. So if you want to know what happens this year, you just have to wait till 2019. So the opiate deaths have remained pretty steady in San Francisco, which is unusual if you look at the rest of the country. What has changed is the proportion of what people die of, which opiates, and in particular, the proportion due to fentanyl, which has increased every year in the last 3 or 4 years. So overall, we get anywhere from 90 to 110, roughly in that range, overdoses that are attributed to opiates. Bystander overdose reversals have skyrocketed. And that may be why, we don't know, why our overdose rates have remained stable, because we have a very educated and concerned drug-using population that look out for each other. So we've had the community access to naloxone since 2003. The DOPE project is called, and multiple sites throughout the city, people have syringe access and naloxone access, and they use it to help each other. We've also given instructions to stagger use and to test out small amounts of drugs. We handed out the test strips for fentanyl, but what happens is they're all positive. So it's very sensitive, but it's not specific to an overdose level. So and when that happens, it kind of becomes useless. But on the other hand, people are testing, that means they're thinking this stuff could kill me, so at least they're a little bit conscious of that. So we suggested if people use in groups that they stagger their use, and aside from the dipstick test, to also maybe try a very small amount of whatever they're using. Methamphetamine use is increasing in the city. Over the years, it's always been, our admissions have been the most for heroin, the second most for alcohol, and methamphetamine has been down below cocaine. But methamphetamine use is increasing, and methamphetamine admissions are chasing alcohol now in terms of almost the second, it's the third highest admission rates. Also, the pain management approaches to reducing risk have been very active in the safety net in particular in San Francisco. And pain management approaches that don't use opiates have been tried, and also reducing the total morphine equivalence is happening, and our county has reduced the average amount of opiate per head more dramatically than other counties around the Bay Area. So it's just it's a slight drop, but it's still not level like other counties are. So we've had a little bit of success in that field of trying to change approaches to chronic pain management, which turned out to be so dangerous. Right now, there are 2,073 people on buprenorphine prescriptions. This is an office-based available medication. How many of you have X numbers? 1, 2. You could all get X numbers if you're physicians and if you're nurse practitioners. An X number is the waiver. It refers to a second DEA number on your DEA license, which is the same number, but instead of the first letter being any other letter of the alphabet but X, the second one is X. So you have 2 DEA numbers. One of them designates you as a buprenorphine prescriber. The California Healthcare Foundation did an analysis of all the counties in the state and their opiate preparedness and their opiate safety. And they said good things about San Francisco, that opiate agonist medication is available easily to everyone if they want it. They also said that if everybody who had an X number prescribed to their limits, there wouldn't be any more demand. So we're well equipped in treatment as well, which may be another factor in why our overdose rates have remained flat. So this is taken from the INDUs as well, and I've included deaths and admissions for each of these drugs. So heroin deaths, 14. I'm including things that were also found by the medical examiner in significant amounts, just to give you a sense of the frequent use of multiple substances that are involved in overdose. Obviously, we've known a lot about sedatives mixed with opiates being dangerous. Sometimes other kinds of stimulants are there, sometimes alcohol. So it's not unusual when you die of an overdose for the medical examiner to find a lot of things there.
Green. LPPI.
We've had 4,077 admissions to treat heroin. These admissions are admissions to substance use disorder treatment, not to the hospital.
LPPI 40,000.
So prescription opiate deaths are higher, significantly higher than heroin, as you can see. was it a code red or something?
Code green.
And a lot of stimulants there too. The treatment for prescription opiates admissions were 419 in 2017. The bystander reversals, as I said, were humongous, 1,247. And we gave out 5,499 kits in the community. This is not naloxone prescribed or co-prescribed in the office or free when you walk into a pharmacy. These are the community distribution. Methamphetamine deaths were 87, as you can see, higher than heroin, but a third of them also had opiates involved. The admissions for methamphetamine, 1,836. Cocaine deaths, 78. Again, lots of them with opiates. The cocaine admissions were 693. And as I said, alcohol is our second, but look how close methamphetamine is for admissions. 1,959 admissions. These are admissions where the primary drug is the drug that's on this slide. Doesn't mean that they don't use other things, that we don't address other things. But when they say, what's your primary drug, that's what they come up with. So I think the opiate treatment medications are pretty familiar. Do you know what they are? There are 3 of them that we consider effective. 2 of them are agonists. Well, one's a partial agonist, but 2 of them are opiate agonist treatment medications. And one is an antagonist given by injection. Methadone maintenance is only available in a specially licensed facility that is extremely highly regulated. And it's really, even though it's outpatient, it's a higher level of care than most outpatient care. You see a nurse at the window every day who gives you your medication until you're pretty stable, and then you take home some of it. Counseling is required, testing, random urine testing is required. And even people who are extremely stable, who come in and pick up, they come in every 4 weeks and take home 27 doses, they're still required to have 1 observed dose, at least 1 a month. Other countries don't do this. Other countries, you can prescribe it, you can go to the drugstore can watch you take it if necessary. So imagine if you could get methadone maintenance at every Walgreens. All those rural areas that don't have any treatment would have treatment. But that's not how we do it here in the States. I was at an ASAM conference once, and we had a colleague from Denmark addressing us. And it was back in the early 90s, and they were using methadone to combat the HIV epidemic. So HIV prevention often includes treating substance use disorder, in particular anything where you would be using needles. And so he was reporting on the use of methadone in Denmark and how it had reduced HIV rates. And he said, we have an HIV epidemic in Denmark. You have a regulation epidemic in your country. And he's right. We've probably killed quite a few people with those very, very severe regulations that people who work can't take methadone because they have to be in that window every day. So that was part of the reason why buprenorphine was developed, which is the second one on this slide. And it's available in many venues in San Francisco, including office-based practice like primary care, mental health clinics, and even lately in street medicine and in substance use clinics. It has a better safety profile than a full agonist. It has a ceiling effect for respiratory depression. And so that's why they scheduled it 3 instead of 2. If it were scheduled 2, it would have to be given only in a methadone maintenance clinic. So for a while, we were very conservative.
Green,
in how we
all
used
clear.
buprenorphine
Code green, all
because,
clear. Code green, all clear.
We were afraid that if a lot of it got out on the street or if it were misused by people who didn't know how to use it, that the DEA would reschedule it, make it a 2, and we wouldn't have it for office-based practice. So in the early days, just out of fear, we were following very closely all the evidence-based clinical trials approaches, and And now we're a lot more loose with it, we're more familiar with it, people have taken it on the street, they know how to do it themselves, and it's become just like any other medication. But initially, we were doing very careful stepwise inductions, starting at a very low dose, doing cow scores every time. By the way, I wanted to mention that ceiling effect that buprenorphine has on respiratory depression doesn't exist. The ceiling doesn't exist for its analgesic properties. So it really is a good analgesic, and you can continue to use it as an approach to chronic pain if you wanted to, or even acute pain in the hospital. Naltrexone injection maintenance is a little later development. It's a monthly opiate antagonist, and it's a somewhat difficult shot to give. It's thick. Reminds me of the benzathine penicillin from the old days, where you almost have to use both hands. And it's given in the upper outer quadrant of the butt. It's really almost in the iliac crest, because you can't put it in fat. It has to be IM. Otherwise, you'll have an injection site reaction. So there's a little bit of training needed, but it's not difficult. It can be done. So I made this slide to help with patient selection, and I put in red the more severe safety issues for each of the pharmacotherapies. The beginning of it, the start of the medication, is sometimes called induction. I think we should just say start, because people don't know what induction is, but I just was so used to saying it that I put it on my slide. Maybe I should take it off. Methadone, you start orally, but because tissue levels take a while to stabilize, you don't know whether the dose is sufficient or not until the person's been on it for a few days. So you have to start low and go slow, or else you're going to overdose the person. And when methadone was started in office-based practice in Australia, in the first week of treatment, people had a higher mortality than they did on the street using heroin, and that was overdose mortality. And so we've all devised kind of slow approaches to starting methadone. And it's okay, because it's only done in these special clinics, and you get to see them every day, and you can evaluate. People end up at 100 milligrams, but if you gave them 100 milligrams on the first day, you might not see them again, because they'd be dead. So using methadone is a little tricky in the first week. Once a person is on a stable dose, they have a lot of opiate tolerance, so they're pretty much protected against overdoses because of that. Of course, it can be, if you took a truckload of something, you could overdose, but it's harder to overdose. And it takes care of the craving, and if you use it, you won't feel it. So it's a real disincentive to use heroin. It makes it unnecessary. So the first week is a danger time with methadone. Buprenorphine, precipitated withdrawal it doesn't kill you, it makes you wish you were dead, but it means that all of a sudden you go into opiate withdrawal. And that's more uncomfortable than if you'd had it naturally occurring by, the opiate gradually disappearing from your body. And when somebody experiences that, then they don't want to come back. It would be like going back to a restaurant where you had food poisoning. So it makes the medication not accessible if you use it that way, or if the person uses it that way. So we're careful not to induce precipitated withdrawal. Of course, that means technically that it's a little harder to start. We have same-day access to methadone. If you get there by noon, you get your dose that day. Buprenorphine, that might not be possible unless the person has a certain amount of already occurring withdrawal, so that we don't induce withdrawal, because buprenorphine has a really high affinity at the receptor and will displace other opiates and induce precipitated withdrawal. So that's what you want to avoid with buprenorphine. Naltrexone, the most dangerous thing is that being on an antagonist for a while lowers your tolerance because you haven't been using opiates basically for a while. And so when people decide to go off of it or just don't want to take their pills, if it's pills, the danger of overdose is higher than if they'd been on an opiate. So we're careful how we use it, and always think about that. Other things to think about in medication selection is that naltrexone, both IM and PO, requires a period of abstinence that's really hard to achieve in the community. People often have a hard time just not using heroin for a week. Sometimes we try 72 hours, but one of the ways to get around that sometimes is to have institutional abstinence. In other words, put people in a residential program, make it harder to find drugs. But really, opiate detox is pretty much contraindicated right now, unless you do it in the outpatient setting because of the horrible overdose death rates. Medication interactions, when you think about that, just remember that methadone prolongs the QT interval, so you gotta watch out with QT drugs. Buprenorphine is still, you can almost eliminate the safety profile by taking it along with a benzo, say. So you still don't want to co-prescribe if you can avoid it. Don't give sedatives with it. Of course, both of the naltrexones, which are antagonists, a contraindication is needing opiates, right? Or the presence of opiates. So you don't want to give an antagonist in the presence of opiates, again, because you precipitate withdrawal. So there are side effects from ongoing use of opiates in general. And obviously methadone and buprenorphine have some of those side effects. Buprenorphine slightly less than methadone, being a partial agonist. And they are, constipation, hypogonadism, and less than methadone, as I put there. With the injection, naltrexone, we also have to put up here, injection site reactions are pretty common, especially if somebody's new at it. So depending on how many shots you've given, it's less likely to happen. And then finally, I put up this as side effect or danger. The venue, the logistics of it, the methadone clinic itself is probably the biggest side effect that people complain about, and the biggest reason they leave. It's just too regimented to fit in a normal life. And so as people get better, then they want to taper off and leave, and there's really no way to graduate, to go to your primary care doc to get methadone. And as I mentioned, with buprenorphine, you need an X number. With the oral naltrexone, adherence is a real problem. We just don't recommend it anymore because people just don't stay on it long enough to have benefit. And then with the injectable naltrexone, it's expensive. So. Yeah, I think I said most of this stuff. This is a flow of care. So, as a summary, safety considerations in the maintenance pharmacotherapy is you're aiming to avoid sedation and respiratory depression. In other words, stay within the person's tolerance. And you want to minimize the long-term side effects of constipation, sweating. And you want to minimize accidental ingestion or dosing errors, etc. And the outcomes that have been shown for the last 60 years or so with methadone are also seen with buprenorphine maintenance, with newer studies showing this. Reduction of drug use, very good retention. It's slightly lower than with methadone. Reduction in HIV and hepatitis C seroconversion, and very good control of withdrawal signs and symptoms, including craving. Okay, now I'm going to talk a little bit about changes, I alluded to this a little bit earlier, we've changed how we approach opiate agonist treatment and how we approach the overdose epidemic, and it's because of the overdose epidemic that we did this. So essentially, the huge number of overdoses have changed our risk-benefit balance. We try to avoid institutional abstinence at all costs, or address it by beginning buprenorphine before release, say from jail or prison, because it increases the risk of overdose. That's been proven over and over. You go to jail, you stop using, you come out, and you overdose. Or you go to the hospital, you're there for 3 months because it was serious, you leave and you overdose. So we try to avoid that. We try to keep people on their maintenance medication or even begin it. We have hospital starts, we have emergency room starts, and in the jail we have starts. We have buprenorphine starts, and methadone is kept in San Francisco. One of the clinics delivers the methadone and watches that people take them. So the methadone is continued during jail stays. We've also started saying medication is treatment, because traditionally these medications have been offered along with counseling, and sometimes the structure is such that if people don't go to counseling, their medication is withdrawn. It's as if they took away your insulin because you didn't see the podiatrist. It just doesn't make any sense whatsoever. These medications by themselves have been shown to be very useful and help at least 80% of people just by themselves. So we start thinking about medication is treatment. It's certainly not evidence-based to withdraw from the medication because of non-compliance if the person is stable on the medication and it's helping them. So we've started approaching the medication as a treatment in itself. We know that withdrawal management is not treatment. You need to do something else besides withdrawal management if you're going to do that. And withdrawal management for opiates should be in the community, where people are exposed to real things in real life. It shouldn't be in a protected setting. Naloxone, this medication first approach can be really life-saving. And then again, we use naloxone to everybody, including people who use stimulants, because some of them have died thinking they were using amphetamine or crack, and they had fentanyl in it. We do have also, was almost unheard of in San Francisco, but we're starting to see a few people where fentanyl is their main drug, that they liked it. It turns out it was contaminated in the heroin, but then it turns out some people like it. So not everybody though. It's a little too sudden for a lot of people. But we have to start testing it in our tox screens. It hasn't quite caught up to us because it's expensive and some of the programs are hesitant to invest the money, but we have to start doing fentanyl urine tests in order to address this. So this is an example of the medication approach I wanted to give you that's from San Francisco. A couple years ago, Dr. Zevin, who's the medical director of street medicine, this is a medical team with social workers who go to the encampments and go to syringe access, people who are homeless. He decided that since he sees people when they're buying needles to go use heroin, that he would say, how about buprenorphine? And so he's really in real time offering people treatment as an option when they're literally planning to go or have the drug with them and planning to use it. And he and his team now, several other people who are prescribing it, work in conjunction with the behavioral health pharmacy at 1380. And the pharmacists there are very unusual. That particular pharmacy, we don't have one like that in the States other than here. It's a mental health pharmacy, and so the pharmacists and clinical pharmacists who work there are specialists in mental health, and psychiatric medications, and also psychiatric evaluations. And some of them are also very familiar with buprenorphine because before it was a Medi-Cal benefit, our city offered it to hundreds of people, and they picked it up at that window. So they're very familiar with the medication. They can do inductions, they can do observed doses, they can send people upstairs for a tox screen and talk to the physician about it and adjust the dose. So This has been over the past 2 years. They have about 350 people now. So it's a major effort that's unusual in the country, and it has to do with the dynamite people we have here in the city. Another thing that's happened that you might hear about is comparing the opiate overdose epidemic to the HIV epidemic. Have any of you worked in the HIV epidemic? Do you know what the 90-90-90 goal is? Yeah, you want to say?
Oh, is the 90%, I might get it out of order, but 90% of people know their status. 90% of people with HIV will be on meds or at least virally suppressed. And then there's one other one.
90% will be viral suppression, yeah. So this is the way the HIV epidemic has set goals over the years, and they've finally increased it to 90. And it means that, as you said, 90% of people who have it are identified. Of those, 90% are in treatment. And of those, 90% are zero virus. So the way you would do it, this is called the cascade model, by the way, because it steps. For the opiate use disorder, it would be X% of people with opiate use disorder are identified. Of those, X% have been treated long-term. And you could use 6 months as a marker, a proxy for that, with opiate use medications, the 3 that I mentioned. And of those, X% are abstinent from non-treatment opiates. So that's a challenge, especially because the funding streams are so fractured that it's harder to follow than HIV. You know, usually HIV is in there, yeah.
So for somebody completely outside of this field, what is the, so this is the goal, 999. What is the actual state of fact in terms of percentages? Do you know?
The actual number
Yeah.
in San Francisco, it approaches, I think it's 70, 80, they're almost there, yeah. San Francisco is really leading in HIV, yeah. When I think about wanting to set benchmarks, you know, for the bottom part, what are the X's? What number should the X's be, right? To do performance improvement projects, it's really hard to find the numbers. Because opiate use disorder is something that's picked up in many different places, by the police, by the jail, everywhere. And so it's not in a central registry where you have opiate use disorder, you know, in a DSM code. That's one problem. We know methadone clinics, how many are in treatment for at least 6 months. We have an idea of the people who get buprenorphine into pharmacy. So the second part might be okay. We might be able to find that. We have 7 methadone clinics, and 8 if you count the VA. And I think the VA tracks this too, so we could probably get that second amount of that part of that data. Now, Trexone would be difficult. That would be really difficult to track because it's not a scheduled substance, so it doesn't sort of on cures. And then in terms of who's abstinent, very difficult. You know, because it's just not something that we have available. Every single substance use disorder program is siloed, and the records are private. 42 CFR privacy, you know, goes along with that, and it's in the way. It's one of the major barriers to integration, really, is the privacy rules for substance use. They were written way before HIPAA, so then they were necessary. Now I'm not so sure. Anyway, that's the reason I put this medication first and cascade model is because I wanted you to be aware enough that these things are circulating in the environment and just be able to follow them as trends. And hopefully they will help with the epidemic. So I'm going to switch to alcohol use disorder. And there are 2 things that need medication frequently. One is acute withdrawal, control of the symptoms and protection of the brain during acute withdrawal. The other one is control of craving long-term to help reduce or stop use of alcohol. So with withdrawal management, you're basically doing a risk triage for venue of where you're going to do it. The treatment ends up being pretty much the same, no matter if it's in the hospital, if it's in a residential program, if you're at home. But the danger of seizures and DTs makes it important to do triage, especially if there's a history of those things. The long-term, we use the CWA to adjust the dose just to keep the total amount of lorazepam low. You could do a taper without it, but the CWA is sometimes also used to help triage, because more symptoms means more danger of seizure. Long-term medication for alcohol use disorder helps reduce drinking, helps reduce drinking days, reduces craving, and contributes to abstinence for some people, and the overall life function is better. And when somebody drinks alcohol and has a mental health disorder at the same time, the functional impairment is significantly more severe. So if you have a dual diagnosis patient, it's important to stabilize both things, or you're not going to succeed in either one. So, and it used to be, if I was working in a substance use clinic and somebody was hearing voices and psychotic, and I would send them to the mental health clinic, the crisis clinic, and they would bounce them back to me, say, he drinks. Like, take care of one thing, then another thing. Well, that's not how the patient is. That's not how they're presenting. You got to do both. So I think it is important. The more we do integration, especially in severe cases, the better the person's going to do. So I'm going to talk briefly about decision points in regard to alcohol treatment medications, and then a fast review of the medications that we have. The inpatient or outpatient question is important for withdrawal. Kaiser, 90% of their opiate treatment for withdrawal is outpatient. In the safety net, 90% is in residential treatment because they don't have someone at home to watch them and help them. And typically they're homeless. So daily monitoring is important, and that can be done by loved ones, but it could be done at the behavioral health window if the person's willing to come in. Sometimes we say, okay, we'll do your alcohol taper at the window if you come in every day and if you go on interviews on the second day. Because otherwise there's a line out the door because people like the benzos. So they come in for that and they don't stop drinking, and it's dangerous. So the safety issue is really what we're thinking about here in terms of the venue for the withdrawal. The hospital, general hospital, sees a lot of this. People are admitted for a variety of things, and it turns out they need withdrawal management for their alcohol. And so they have an naltrexone project where an LVN goes to the bedside and does motivational interviewing and tries to get them to agree to go home on long-term treatment medication. It's a good program. So within the DPH, we have, as I said, home withdrawal management, which is rare. We have referral to the treatment access program. How many of you sent somebody to TAP? Yeah, it's well known for evaluation. And sometimes TAP can send somebody to social model detox, which technically doesn't have medications, but with a baggie from the pharmacy, so that the staff at the withdrawal management program can monitor taking their alcohol withdrawal medication. Beds and meds is kind of what we see in the residential programs. It's really outpatient detox, but in a bed, because the person's not safe otherwise. Joe Healy, for example, does a lot of this, and they have nurse monitoring around the clock, and they do CWAs and adjust the dose accordingly. We also have a sobering center, which is a place where the police and the ambulance take people who are in trouble with alcohol and severely drunk. And the nurses there evaluate them and triage and decide do they need to go to the hospital or not. It's a way to alleviate the load at the hospital, to help the person have a more appropriate level of care, less restrictive and more what they need, like a warm meal and laundry for their clothes. And of course, the nurses there refer people to detox. And if there's a bed waiting and somebody really wants to go to detox, they can even start the alcohol treatment medications there. They have a protocol for a couple days until they get into drug healing. So and these are our criteria that are on our handouts, and this is on the website if you want to look at them, but the patient never had seizures, patient not on other sedatives, patient is at home with an involved other, patient able to participate in self-care. So those would be the outpatient treatment considerations. The long-term medications, I'm mentioning the top 4. There are a number of other things that are used off-label that are not quite as good as these. You'll notice naltrexone appears here again, and naltrexone is an opiate antagonist. It reduces the reward of alcohol, not for everybody, but for 1 in like a quarter or a fifth of people who come in. It's very dramatically helpful. For others, it may not be at all. So in some places, people take the pill as a before party thing. So if they don't want to drink as much, they'll take one of these tablets and find themselves drinking less, even without having a diagnosis of alcohol use disorder. Disulfiram is a deterrent. It's not really a treatment. It interferes with the metabolism of acetaldehyde, and that causes unpleasant symptoms. Acamprosate is a GABA modulator. A lot of people don't know really how it works. A lot of people just don't really know a lot about it. Possibly an NMDA antagonist. Basically, it reduces the jitteriness in the brain, and that's what a lot of withdrawal symptoms are. And topiramate is off-label. It's a seizure medication and a migraine medication, and it's used to reduce craving and withdrawal symptoms. Again, it reduces the brain jitteriness, which is glutamatergic. So here are some safety considerations if you're trying to pick which medication. Naltrexone will induce precipitated withdrawal from opiates, so anybody who needs opiates or who very likely will need opiates, you wouldn't want to use it. It would be contraindicated. A lot of times we do tox screens to see if there are opiates on board. We might even do a test with naloxone ahead of time before we start the medication. It's long acting, so once you give it, if you induce withdrawal, they're sick for a while. It is contraindicated in severe liver impairment. Some people use enzymes to check that. There are various ways. A lot of these things, if you take it in context with alcohol, which also affects the liver, sometimes in severe alcohol use disorder, you're weighing whether you want your bottle to be at the bedside when the person dies, or do you want Jack Daniels to be there? You know, it's like they drink so much that you really don't know which it is. Is it the alcohol, is it the medication? But you don't want to contribute. And in particular, disulfiram. If you're going to induce a bad reaction and somebody starts throwing up, which is one of the things that can happen, you certainly wouldn't want to give it to somebody who's in the hospital every other week with a GI bleed, right? You don't want to induce a GI bleed and the person bleeds out. So you have to think about what their usual symptoms are and how sick they are. But almost all of these are really contraindicated in severe liver impairment. Acamprosate, there have been some suicides reported, which I think is important for you guys to know. Generally, it's used less in major depression, and a lot of people experience diarrhea, and it's lots of pills to take. This medication is unusual because it's not metabolized at all. It's excreted exactly as it is, and not a lot of it is absorbed. So people take it 3 times a day for it to be effective, and it gets ridiculous. Topiramate, people are drowsy and feel weird and are sedated early on until they get used to it. So there's difficulty if you're trying to learn something or remember something and it's just annoying. So a lot of people don't survive the buildup of this medication just because of that. And you can't give it in renal failure. How are we doing for time? Good. So the patient selection in general goes like this. Naltrexone is first line. unless the patient's on opiates. It reduces craving and heavy drinking. Disulfiram is for somebody who's motivated to stop drinking and understands the risk of alcohol consumption. So you have to have a person who's alert and remembers that they have this in their body. I use it a lot when I was in the methadone clinics because people are there every day, and if they want to take it and they want it to be encouraged, you can even dissolve it in the methadone. So even if they have take-homes, they're taking it. I've had a few cases where people were using cocaine a lot, along with alcohol, and they agreed to go on it, and then they were high on cocaine and forgot and drank. People often drink alcohol when they use stimulants to control the unpleasant, amped up feeling, and they both ended up, young women ended up in the emergency room with brain scans and all kinds of, nobody could figure out what was wrong, and it was that they were on disulfiram. And on top of being cocaine toxic, they had alcohol and developed a reaction. So just be aware, just don't give it to somebody with severe Alzheimer's, for example. They don't remember it, so they're. And adherence support often helps with disulfiram dramatically. Acamprosate, as I said, a high pill burden. You see, we put it third here because it doesn't make anybody real excited, but we have a lot of people in our system on opiates, so naltrexone would be contraindicated, so you might consider this for that. And then topiramate, you might want to choose it for somebody with a known seizure disorder or failure to respond to the other things. Sometimes you can boost the effects of these by adding gabapentin. We just try it, and we try it for everything, don't we? And some people do so well with that it's even used sometimes for withdrawal. There are a few published double-blind studies that compare it pretty good compared to lorazepam. So gabapentin is another off-label use that might help some people. These are the pictures. I think the rest of these slides are, if you wanted to look something up and find out what the research is, side effects, hepatitis, the black box warning, the box warning, and disulfiram. See what I have here. This is if you want to know more. I don't think I need to review all these slides, but they're in your handout. Again, topiramate's off-label. And naltrexone works by reducing the reward, which naltrexone, you don't need to be abstinent. You can take it just to reduce use. And that's a very appealing thing to a lot of people who don't want to be abstinent or who can't find it in themselves to become abstinent before they come to you for help. So I think in that way it's appealing to the patients. Yeah, they all have side effects. So when you monitor for response to these medications, you ask about binge drinking, drinks per day, abstinence. You might want to look at psychiatric symptoms if it's dual diagnosis and see if they're improving. There is a craving score if you want to use it. It's a 5-question craving score. And you look for social stability, quality of life stuff, functioning. And then you'd want, of course, improvement if there is damage of some kind, like liver disease. So in summary, when you think about alcohol treatment, use placement thinking for the detox setting, the location, and start the long-term medications. You could start it like on the 4th day of detox, most of them, or right after. And then consider craving and protracted withdrawal, if that's something you have, if you're not controlling the craving. So the summary is effective medications exist. They're not perfect for everybody, but they're certainly worth trying and can make people's lives a lot friendlier, happier. So we have, looks like 5 minutes for questions. Any more?
I have a question about what you feel is the purpose of the X waiver and whether you think that requiring the X waiver could be a barrier to the dissemination of buprenorphine.
The X waiver, which is essentially is a requirement for training,
Yeah.
is definitely a wet blanket. It's ridiculous. Now, the new support bill has, so back in the day, I've done maybe 40 of those courses, maybe 50 by now. And the reason for them was that people had a medication, they didn't know anything about the illness. So it would be like if you never heard of diabetes and suddenly you're supposed to give people metformin. You don't need just about metformin, you need to know like what you're monitoring, what the chronic illness is. So that was the thinking behind it. We didn't want it to get a bad name and be taken away because we tried so hard to get it on the market and available for office-based treatment. But it was basically fear-based and probably still is. So the support bill has a section in it where they're probably going to look at medical school education and residency education. And if they decide that it meets the standards, then somebody can get their X number immediately without going through another training. Make it a little easier. The other thing that's a wet blanket is the DEA visits. Having to keep track of your census is not something we do. You know, it's kind of weird. And how would you do that in an electronic record? Can you do a report? Who do I have on buprenorphine and when did they pick up? I mean, it's kind of hard to check.
I got two small questions. So one is, you showed us the 3 medications, treatments that are available, but is the SF Department of Public Health also looking into heroin-assisted treatment? Because maybe just as a pilot trial in the future, San Francisco would maybe be the city. And the second one is, just on Tuesday, I was in Sacramento at the Scott Wiener's office to discuss this one bill on conservatorship. And I wanted to know what your statement is there, because of course we have a lot of people that show up multiple times in emergencies, maybe up to 70 times, but still I don't believe that this may be the solution.
Yeah, so I think you're talking about AB 1045. Yeah, there's a recent bill that's called Housing Conservatorship, I think is the short name for it, that allows community conservatorship. And I've never been very impressed with the effects of conservatorship with medications, with substance use disorder. If you're looking at mental health, you're trying to get people on medication so their thinking clears. If you're thinking about substance use, you're trying to get them off their drugs, right? And so they clear up. You know, you put them in a confined setting, they start looking normal, and the judge says, okay, go. We can't conserve this person, they're thinking straight, they're normal. So even with the history sometimes of frequent emergency room visits, or frequent harm to self by being in front of traffic and being psychotic, etc., it's really hard to make it work. I think what we need really is variations of housing. In San Francisco, we've had housing first, and the supportive part of supportive housing hasn't been very good for substance use. Hasn't been very effective. So I think we need a variety of housing options. For example, when somebody goes to residential treatment and then they go back on the street, it's not going to work. So like a residential step down while they engage in outpatient and have more rehab, that would make more sense. And it's being piloted at Health Right 360. And I think like the board and care homes that some people have in mental health, just a house to live where somebody watches out for you, might be a good model for substance use. We have fewer and fewer and fewer of those in the city because of the income disparity is so huge, $1 million. So in general, the city's in favor of it, so we'll probably do it, but I'm not even cautiously optimistic. I'll be surprised if it works, pleasantly surprised. We're always in miracle readiness, right? So one area that I think we can develop in the city that doesn't have to do with alcohol or opiates, has to do with amphetamines, stimulants. We need to figure out like an approach to dependency management that's solid and effective and throughout every venue, so that people can have because that's one of the evidence-based practices that's not on our list usually. You know, LMI, CBT, and a lot of things that work, but contingency management in particular is proven for stimulant use disorder. So it's going up. We need more of it, right? Is that what you asked me? Is there anything
The
else?
first question was related to heroin-assisted treatment.
Heroin-assisted treatment.
Because like in Switzerland, where I'm from, we have some people who don't respond to methadone
Yeah.
or either treatment, and for them, if they are willing to be in treatment, this can be a good
Yeah.
form.
Yeah, like in Vancouver was very successful with heroin-assisted treatment in the Dutch studies. Yeah. Heroin-assisted treatment has been tried in other countries. I think it's a challenge for here. I sometimes I say I shouldn't say anything like this. Probably not in my lifetime. I see it. But I said that about legalization. Here we have legal cannabis, right? In the 70s, we read this book, Licit and Illicit Drugs. Have any of you read that? Consumer Report on Drug Use. And they came to the conclusion that the war on drugs was the worst thing about them. And in fact, the way we've enforced it, not only has it been a failure in terms of controlling drug use, look at the overdose epidemic, but also the way it's been enforced, it's been just a continuation of slavery. It's just not right.
Can you talk a little bit about what the status is on the safe injection sites in the city and data on it?
So we don't know what the new governor is going to do, because when he was here, I think he was in favor of it back in 2007 or so. The outgoing governor vetoed it. So it did pass, and then it was vetoed by the governor. So with the reason we need the legal backing is that you can lose your license if you're helping people use drugs. So you have to have some kind of legal thing, almost like a Samaritan law, Yeah. So right now it's just on hold to see what the new governor does. Yeah.
What are your thoughts on wet housing?
Alcohol management.
Yeah.
Yeah, we need that. Yeah, we had, and our previous director, Barbara Garcia, was in favor of it. We just didn't have the money. So what you need is an open plan housing location. You need careful screening of who's appropriate for it, because not everybody's appropriate. And then you need staff to do the alcohol titration and monitoring. And so we did make up a proposal at one point, maybe 5 years ago, and it just was never funded. So I think it's possible, and I think it's a good idea. We even have providers that are willing to sign on if we want them to do it. So it's one of those varieties of housing that we need is alcohol management housing. Yeah, although heroin management, I don't know. I really doubt if we'll have it. If we can't even get supervised injection.
We're past 1 o'clock. I mean, I don't know, Judy, if you have a few more minutes, but otherwise we
Yeah, I can stay
wrap
if you
up.
want.
Thank you very much.
Yeah.